Hi there, my name is Linda Myers, and today we are going to talk about the what, why, and how of cardiac rehab. If you are an RN, an LPN, or an advanced practice RN, this training is worth 1 CE that you can get at the end of the session. So I am a registered nurse. I have more than 35 years of experience as a nurse, and in addition to working in intensive care units and recovering open heart surgery patients, I've also worked in hospice, emergency room, urgent care centers, kind of across the board. And I've been a professional educator and CE provider now for some time. So working on both sides of the cardiac rehab kind of continuum, I've really gotten to see the depth and breadth of what patients go through, both before surgery, in their immediate recovery period, and then as they transition, the education that's needed as they try to resume their normal lives. And that's what cardiac rehab is about. It's an outpatient program designed to help people get back to where they were before their heart event, essentially. We basically have 4 objectives to meet today. We're first going to talk about the purpose of cardiac rehab and its benefits. Then we're going to identify some of the common qualifying diagnoses that apply to a cardiac rehab referral. But we're also going to discuss some of the major barriers to this referral and participation process, because there are difficulties and barriers on both sides, both the referral process side and on the patient side. And then we're going to identify some strategies to overcome these barriers. And then we're also going to just take a little bit of time to review some of the anatomy and physiology of different types of heart disease so that you can understand which patients these services are going to benefit. So cardiac rehab is first and foremost a Medicare approved program. It's been around for about 30 years, maybe more. Generally, it is staffed by a multidisciplinary team. It is a medically supervised program that provides progressive, individualized education, disease management, behavior modification, exercise training, nutritional counseling, behavioral counseling, risk factor modifications, all of these things, in addition to the emotional support that people need to get over the fear of exercising after a heart event and to give them the confidence that they need to re-engage in their lives. In the United States, heart disease remains the leading cause of death for men, women, and people of most racial and ethnic groups. Although the focus of our talk today is about cardiac rehab, you may have also heard of something called pulmonary rehab. Pulmonary rehab is a very similar program. Oftentimes, cardiac and pulmonary rehab are housed in the same center, and they're similar in most aspects. In other words, you have to have a qualifying diagnosis, but with pulmonary rehab, the qualifying diagnoses are a bit more broad. It can include things like a history of respiratory failure or lung cancer, things like that. However, most patients that are seen in pulmonary rehab have COPD with a GOLD stage 2 or higher on their pulmonary function tests. But we also see patients with interstitial lung disease, pulmonary fibrosis, asthma, and then brand new because of COVID is that patients who have long haul COVID, in other words, they are still having symptoms 4 weeks or more after their disease diagnosis. So whether they were ever hospitalized or not, if they are 4 weeks in after having had COVID and still having symptoms, they qualify for pulmonary rehab. And this is new in 2022. Medicare finally opened up that diagnosis. And that's great because now we have a way that we can give a resource to patients who are struggling with long haul COVID and try to help them with There are different ancillary symptoms like POTS and fatigue and shortness of breath and exercise intolerance. So that's pulmonary rehab. And again, we're not really talking about it, but they do go hand in hand. And I want you to know that both are possibilities for patients who are struggling with chronic illness. Cardiac rehab is generally made up of a multidisciplinary team. And that can include people like physicians, nurses, exercise physiologists, nutritionists, social workers, physical therapists. It could be a number of different people. We always are trying to bring different areas of expertise together in order to benefit our patients. And so depending on the program, you may see different teams of people. Medicare does require that we have a physician who is a medical director of the program. So they review charts every 30 days, and we have to send them reports that talk about patient progress and how they're doing. And that's someone who we can also bring issues to. But we also work closely with patients' cardiologists and other experts and referral sources, depending on what the patients need. It ends up being almost like a case management situation because we end up getting to know the patient really well, and then we can see where their needs are, where the gaps are in their education or in their care, and then we work together with other team members in order to try to help resource them. Most centers are staffed with people who have not only basic life support but advanced cardiac life support. And there is almost always a code card or at least an AED immediately available in case of an emergency. Let's talk a little bit about the basics. So Medicare approves 36 visits for qualifying diagnoses. And most commercial insurances will follow Medicare guidelines. And so most insurances will also give 36 visits for a qualifying diagnosis. That being said, some insurances require very high copays, and some insurances require that we send them chart notes and that there's proof of medical necessity. Some only approve 24 visits, but I'm just kind of talking broad brushstrokes here. By and large, 36 visits is the typical for cardiac rehab. Now that breaks down into an average of 3 days a week for 12 weeks. And that's because studies have shown that that is going to give the most benefit for patients going through cardiac rehab. It takes about 90 days to build a habit. And so during that 90 days, while they're coming, most of them 3 days a week, although there are some programs that offer 2 days a week or even 5 days a week. But let's just take the typical 3-day-a-week program. We're also working with patients to develop a home exercise program that is something that they can follow once they graduate from us. And so it's a progressive thing that takes time to identify what their resources are, whether they have exercise equipment at home or maybe they have a gym membership, and to work with them to develop something that is sustainable for them after the fact. The benefits of treatment are great. Cardiac rehab has been a Tier 1 recommendation from the American Heart Association and the American College of Cardiology for quite a long time now. And there's a reduction in morbidity and mortality. Patients who finish cardiac rehab have a 36% less chance of having a future event, which is pretty darn good odds. Not to mention the fact that with all of the risk factor identification and education and behavior modification that we work with, in general, we are helping patients just to live healthier, happier lives. So really there are no downsides to committing to cardiac rehab other than the fact that it takes time and it does take effort and a commitment on the part of the patient. And sometimes that's the biggest barrier that we face. A lot of people ask kind of what is the normal age range for people participating in cardiac rehab? And it really varies, honestly. I've personally treated a patient as young as 16 years old who had a cardiac arrest while running for the bus and ended up with a single vessel bypass. I've also had a 95-year-old patient. His name was Gordon, and he was amazing. He used to walk 5 miles on the weekends, and then he would tell me that he would carry his laundry down into the basement, do a few push-ups on the stairs while he was down there, and then bring him back up. He was just a joy and so vibrant. So there's really no one who's too young or too old. I would say the average age is somewhere between 50 and 75, but it really varies. And then the other thing is we see people with all different types of musculoskeletal difficulties and limitations. So we can see people who come in with a cane or a walker or even a wheelchair. We have ways of working with patients with different types of equipment and different types of exercises depending on what their limitations might be. So if they have a rotator cuff issue, or they've had a hip replaced, or a knee issue, some people can't walk but they can ride a bike. Some people can ride a bike but they can't walk very far. And so we are experts at finding ways for people to not only strengthen and condition their muscles, but also increase their stamina and the strength of their heart, even in light of having different limitations. Now, I'd like to take just a couple of minutes to tease out some of the different types of heart disease and review the kinds of patients that would most benefit from our program. So the kinds of diagnosis that you're going to see, and then why what we do is a benefit in those situations. There are basically 3 different kinds of things that can go wrong with a person's heart. It's generally either a structural problem, an electrical problem, or a blood flow problem. Within the realm of the structural problems, we have heart failure. And heart failure can be confusing because there are different types of heart failure, and it's very hard to keep them straight. But for whatever reason, in heart failure, the heart muscle or parts of the heart muscle are not working correctly. And so you can have left-sided heart failure. So remember, the left side of the heart is the workhorse. Its job is to pump blood through the aorta to the whole rest of the body. So when the left side of the heart isn't working well and gets sick, people really don't feel well. They have very low energy, and so it's just very difficult for them to function. Heart failure is a little bit like blood pressure. If you think about blood pressure, it can be systolic in nature, a problem with the squeezing, or diastolic in nature, which is a problem with the relaxing and the refilling of the heart. And so the ejection fraction is usually low in systolic heart failure because it's a problem with the squeezing. And that's going to be important to remember as we talk a little bit more about the referral diagnoses for cardiac rehab. But diastolic heart failure happens because the heart muscle kind of becomes stiff and it can't relax and refill normally. So the ejection fraction might be normal, but the heart still isn't functioning properly. So both of these are considered different types of left-sided heart failure. But in congestive heart failure, that's a condition that happens because the pump isn't working properly. You may have heard of congestive heart failure, and that is a condition where the pump isn't working properly. So your heart can't always, if it's not strong enough, it can't pump all the blood and fluid all the way down to your feet and then work against gravity to pump it back up. It's not strong enough sometimes. And so I kind of think of it like a car that's waiting alongside the highway for a tow. Your heart decides that it can't pump all of that fluid up, so it's going to leave some behind, usually in the feet, the ankles, the legs. And then it just says, well, later on, maybe when this person's laying down, I will pick up some of that extra fluid and bring it back to the heart, but I just have to prioritize. And so the heart prioritizes and can't always pump. And so third spaces that fluid, which causes edema. And when that's happening, we're trying to determine, is the fluid actually backing up into the lungs as well, because that's the danger of congestive heart failure, would be pulmonary edema or ultimately respiratory failure, because the heart just fails. It's not able to pump. So it starts out by leaving fluid down at the feet, but then eventually the fluid just backs up into the lungs and causes difficulty breathing. So right-sided heart failure is typically a result of left-sided heart failure, if that makes sense. When your left side just gets worse and worse, then the fluid eventually pushes back through the right side, backs up into the lungs, and you can also get pulmonary hypertension if you have this chronic, long-standing issue as well. So that issue with the pump with the structural system was the first type of issue. But the heart also has an electrical system, so that sends signals, electrical signals to the heart muscle, telling it to fire and contract in a specific pattern that we call normal sinus rhythm. And so when the electrical system is working properly, the atria and the ventricles contract in a normal rhythm. But shorts and misfires can occur in kind of the wiring that causes the heart chambers to fire erratically. And when that happens, it leads to rhythm issues like atrial fibrillation and sometimes ventricular issues, and that causes a disruption in the oxygen and blood flow to the heart, which then can cause symptoms. Things like atrial fibrillation aren't necessarily life-threatening, but they can get worse, and they can degrade and lead to other things that can lead to cardiac arrest. So patients that we see in cardiac rehab with electrical problems are sometimes people who have chronic atrial fibrillation, or they've had a pacemaker placed, or an implanted defibrillator placed because of continuous issues. Sometimes people have had an ablation where they go in and they try to identify the nerve that's causing the misfire, and then they try to deaden that nerve so that the heart will reestablish its rhythm. But anytime you have an abnormal rhythm, it can be dangerous to exercise, and so they like these patients to come to cardiac rehab to be put on a heart monitor, which everybody gets put on a heart monitor. We take their blood pressure and their heart rate before, during, after exercise, that kind of thing. And so it's a safe way to kind of see how is the heart going to respond under stress. Now, last but certainly not least, you can have a problem with the blood flow, which means that oxygen doesn't get where it needs to go. The blood is what carries the oxygen, and when the oxygen can't get through, then the body systems can't function optimally. And so blood flow blockages tend to build up over time. Now, in this top picture here, you can see kind of the lining of the artery is nice and smooth. But in the bottom picture, there's a little fissure or a problem with the lining of the artery. And so you can have two mechanisms of coronary artery disease. And one is where fats just build up in the blood, and then when the lining of the artery is degraded, sometimes because of stress, inflammation, high blood sugar, the chemicals in cigarette smoke, all of these things degrade the lining of the arteries. Instead of being smooth, they become jagged, and then the fats catch on them. And so you can have a buildup, a progressive buildup of fat that sticks to the walls of the artery, that stick to each other. And instead of having an artery that is this big for blood to flow through, then it's this big and this big and this big. And then when you have a very small diameter of artery that has good blood flow, sometimes those fissures, like in that bottom picture, can break open, and then you have a little bit of bleeding. And then what happens when the body senses bleeding is it tries to form a clot. And so you can have a complete blockage of a coronary artery or a mostly blocked artery, and both of those will cause symptoms. They will cause pain, because a chest pain is a cramp in your heart. Your heart's a big muscle, so anytime your muscle doesn't get enough blood flow, it cramps, and that tells us something. It sends a signal to us. So chest pain is a cramp in your heart muscle. So obviously not everyone that comes to cardiac rehab has coronary artery disease, but I would say that the vast majority does have coronary artery disease that has been either caused a heart attack, or they've had some type of an angioplasty or stent to open up that artery, or they've had bypass. So there are basically three ways that you can treat heart disease, and we're going to talk about those next. If a vessel is not 100% blocked, they can thread a wire up through the blockage, and then there's a balloon that is attached to the outside of that wire. They blow the balloon up and it compresses the plaque against the arteries to open up the blood flow. Now, what we realized a number of years ago was that sometimes those plaques that got compressed would reocclude, or they would become destabilized, and they would break off sections, and those would go to other narrowed arteries and cause another event. And so they started putting a mesh stent around the balloon, so that mesh compresses against and kind of gets stuck in the plaques, the fatty deposits, and then that mesh stent stabilizes that area. And so it's kind of like when you're on the highway and there's a big wire mesh on the side of the hillside so that the landslides don't come and throw rocks on your car. That mesh is designed to stabilize the hillside a little bit and to protect the cars. So that's kind of what PCI or balloon angioplasty, all of these are names for that same type of procedure where they go and open up a blockage. Now, there are some times when they can't do that for whatever reason. Maybe the blockage is at a bifurcation of a major artery in the heart, or maybe there are just too many blockages, and if they start going in and trying to mess around in there with angioplasty, it's going to destabilize the heart even more. So sometimes they will choose to bypass the blockages, right? So they take a vein or an artery from your mammary artery or the veins in your legs, they create a graft and they sew it on above and below the blockage or the blockage area and reestablish blood flow to an area of the heart that isn't used to having good blood flow anymore. So that's what a coronary artery bypass or CABG is done for. It's because there are either too many blockages or they are not able to be stented. So we used to do something called TPA, just as a side note, and that is kind of like a Drano for your arteries. It's a medication that's very strong, a clot dissolver or a clot buster. But what we found was there was just too much risk in giving those medications because they come with a high bleeding risk, strokes and other things. And since we became so good as a medical community at getting patients into the cath lab quickly when they're having symptoms of a heart attack, doing the intervention and doing angioplasties and stent has become kind of the first line instead of doing the clot busters. And sometimes people just have a bad valve. So the valves are those one-way doors between the chambers of the heart that open and close as the blood goes through them. And sometimes the actual valves themselves are bad. They're either floppy, and so the blood backs up, or they're too tight, or what we call stenotic, and it makes it hard to push all the blood flow through. So either way, whether they're too tight or too floppy, sometimes they need to be repaired or replaced. So that is another category of patients that we see in cardiac rehab if they've had a repair or a replacement of a valve. And that includes the minimally invasive procedure for aortic valves, now called TAVRs or TAVR. So those patients are also eligible for cardiac rehab. In any of these situations, including, all of the stenting and CABG and things like that, it takes time for the heart to readjust to having new blood flow. Most of the time, patients have seen a slow and steady decline in their energy level, and so they've become more and more deconditioned. And the safest way to rebuild the heart and to rebuild stamina is in a controlled environment where they're monitored and they have staff members there who can intervene in an emergency. Most people who have had a heart attack or some type of a heart event are really scared to exercise after they have an event. And so while, yes, they can go to the gym, most of them don't. And the small percentage that do go back to the gym tend to exercise too hard because they are in denial about the slow, progressive way that they ought to be safely increasing their endurance. And so then they run into problems there. A lot of people think that just because they had their problem fixed by a stent or a bypass, that they're good to go. But in reality, they only fix the worst offenders. So you could still have an artery that is 40 or 50 or 60% blocked, and maybe they chose not to do anything about those. So in other words, it's never a one and done situation. Once cardiac disease develops, it's a lifelong diagnosis and a lifelong disease risk. So people who don't change their diet, who don't exercise or quit smoking or manage their stress or control their diabetes, it's like we're just placing a Band-Aid over their problem, but they're not really going to solve it in the long run. So cardiac rehab is about getting to the root of the problem and trying to start identifying causes and make positive changes in people's lifestyle so that they can live with this diagnosis and thrive for the rest of their lives. So let's go back to this question of, can't they just go to the gym? Like I said, the answer is yes, they can, but sometimes people are too scared, or sometimes they don't know their limits and then they end up doing too much. So in a traditional gym situation, there is no supervision, there's no cardiac telemetry, there's no one taking your blood pressure or your heart rate. Now, some people are wearing Fitbits or Apple Watches and things like that, so that is helpful, and we do work with those types of wearables down the line when we're helping people to design a home exercise plan. But in the interim, in the first part of their recovery, there's no way for them to really know if they're doing too much or if there are subtle things happening with their heart while they're stressing it. And I guess the biggest thing is that if you don't have any behavior modification, then what got you into the situation is not likely going to get you out of it. And so having the opportunity to educate patients on exercise and proper training techniques and things like that is a really important part of the program. Like I said, in cardiac rehab gyms, we're monitoring, we're doing blood pressure, we're taking their weights, we're monitoring their symptoms, and then we're also being able to give them guidance on their medications, what they are. I can't tell you how many people have no idea why they're taking things or what the risks are or what they should be looking out for. There just isn't oftentimes enough time in a doctor's office appointment to go through all of the things. And so, yes, there are guidelines set up along the way where they're supposed to be getting this information either before they leave the hospital or with their first visit or whatever, but oftentimes for a variety of reasons those things fall through the cracks and people don't understand their medications. The other thing that can happen is if you hit someone with a lot of information right after their event when they're still recovering in the hospital, sometimes they're very shell-shocked by just the enormity of dealing with a new diagnosis, and they don't retain any information. And so it requires a few different exposures to that information in order for it to sink in. Something that I really can't stress enough about cardiac rehab is the social support and the emotional support that they get by coming to the gym and exercising with other people who have had a similar event to theirs. So it's very hard sometimes for patients' families to understand why can't they just do this or that. When they come to the gym and they meet other people who also had a heart attack or who also had a valve replaced or whatever it may be, even if those people don't become fast friends, it's still such a supportive environment where they can relax and know that they're well taken care of. and that they have that camaraderie of people who understand what it's like to live with heart disease, that it helps them to settle in sometimes to their diagnosis, to accept it better, and to understand that they're not the only ones having to make changes. So let's talk about some of the things that qualify patients for those 36 visits. And remember, these are Medicare-approved diagnoses, and most commercial insurances are going to follow with those same requirements, okay? You don't have to check benefits, though, or anything like that. If you think that a patient has one of these next 10 diagnoses, and they might qualify, just make the referral. Your job as a healthcare provider is just to make the referral. And we have office staff and people who are checking diagnoses and doing chart reviews and things like that. And if it doesn't work out and we can't see that patient, then we'll just deny the referral. But if you want to simplify things, then just when in doubt, make the referral. And if we have other questions, we'll get back to you. Or if for some reason we just can't find a qualifying diagnosis, then we'll let you and or the patient know. But the first one, the most common one, is an acute MI or myocardial infarction. So this can be a non-ST elevation MI, an ST elevation MI, or what they call a type 2 MI. So a type 2 MI is where, let's say, a patient comes into the hospital for a completely different diagnosis, like a hypertensive crisis. And because of the stress that is put on the heart during that hypertensive crisis, their troponin, that hormone that releases and increases when there's damage to the heart muscle, it goes up above the threshold of a level where we will call that a non-ST elevation MI. Even though they didn't necessarily have blockages that caused a heart attack, if they have that bump in troponin, technically they can attend cardiac rehab. So when would you use this? Well, if you've got someone who is at high risk for a cardiac event, and maybe they had this bump in their troponin, but they're also they have a obesity and diabetes and a high history of high blood pressure, right? Or they're a smoker, or all of those things, right? And you know that they have just a very high risk level. You can get them into cardiac rehab under the type 2 MI, under an NSTEMI, and maybe we can work with them and prevent an actual event from happening down the line. And so that's one way that just comorbidities and a high risk for heart disease and for a heart attack can be kind of intercepted, if you will. If they've had that heart attack within the last 12 months, they qualify. So even if you're seeing someone in office and they had a heart attack 9 months ago, but they never got a referral for cardiac rehab, as long as that referral happens within the 12 months after the event, they can still go. So even if we don't catch them right after the event in the hospital, or maybe they're not interested at that time, the window doesn't close on that for 12 months. A history of a bypass graft, like I said before, when they do the bypass that reestablishes blood flow to the heart. Anytime there's a angioplasty or a stent, so just a cardiac cath that is a diagnostic cardiac cath, but they don't have to do any interventions, doesn't necessarily qualify. But if anytime they do an intervention, it's an automatic qualifier. We talked about heart valve repair or replacement. That's a qualifier, whether it's an aortic valve, a mitral valve, one of those TAVRs, any of those qualify. And then stable chronic heart failure. So remember back, we were talking about ejection fraction. So according to Medicare guidelines, a person has to have 35% ejection fraction or less in order to qualify for cardiac rehab. Diastolic heart failure does not qualify, except in certain situations that we'll talk about in a moment. But in general, it can't have the diagnosis can't have the word acute in it. It has to be chronic. So a lot of residents will put in the diagnosis for discharge from a hospital, acute on chronic heart failure, meaning the person has chronic heart failure, but they've had an acute event. And that's not a qualifying diagnosis for the referral. It has to be chronic and it has to be stable. In other words, right after they're discharged from the hospital, we have to wait 6 weeks before we can see them, because Medicare requires that they have 6 weeks of optimal medical therapy before we then admit them to cardiac rehab. So they still have a qualifying diagnosis, but we have to wait the 6 weeks. And that is also because oftentimes when someone comes into the hospital with an exacerbation of heart failure, medications are changed. And so we want to make sure that a person has had a chance for their body to adjust to those changes, maybe in diuretics or things like that, before we admit them to cardiac rehab. Now, these next 5 are also all approved by Medicare for diagnoses for cardiac rehab. It's just that these are a little bit less often seen. So if someone has a heart or a lung transplant or a heart-lung transplant, that's an automatic qualifier. And sometimes when people have very bad heart failure, like a very low ejection fraction, maybe 10 or 15%, and they're on the list for a transplant, but they haven't gotten one yet, sometimes they will place what's called an LVAD, or a left ventricular assist device. And so having one of those placed is a qualifier for cardiac rehab, whether it is a bridge to transplant, or some people just aren't a candidate for transplant. And so they call it destination therapy. In other words, they're going to place this LVAD and the patient is not going to go on the transplant list. They're going to live with this LVAD for the rest of their life. Either of those situations qualifies for cardiac rehab. And then I told you that sometimes in special cases, patients with diastolic heart failure or pulmonary hypertension can qualify for cardiac rehab. And those situations would be when there is a physical therapist that is employed by the cardiac rehab department. Sometimes they can see those patients under PT codes, and they can work with those patients but still monitor them and things like that. And so that's kind of a hybrid bridge program that some programs will offer. And so you can always inquire of the cardiac rehab program in your area, whether or not they have a PT there and whether or not they can see patients with diastolic heart failure. And then lastly is peripheral artery disease. Now, this is not blockages in the heart itself. This is blockages in the legs that cause intermittent claudication or pain when people are walking. When people have this, it's the same mechanism of coronary artery disease, because that buildup of blockage and plaques happens everywhere in the body that there's an artery. It doesn't only happen in the coronary arteries. So if you have blockages in the veins and arteries that feed the legs, the protocol that is the preferred protocol for treating that is called a SET protocol, or supervised exercise therapy. So it's a specific treadmill protocol where patients walk at the same speed all the time, but then we progressively increase the incline, which causes the valves and different parts of the musculature and things like that to be conditioned around the legs, and so can help sometimes with pain. So some vascular surgeons will do a bypass, a popliteal or fempop bypass, and do that first, and then send patients to cardiac rehab for this SET protocol. And some of them will try it first, and they'll say, "Hey, go do 36 visits of cardiac rehab, and let's see if we can not have to do surgery." And so on either side, you may see that for peripheral artery disease. So if you find a patient who comes into the office and they are just complaining that they can't walk long distances, that progressive deconditioning is going to become a risk to them as well. So it's worth a try to take people through the SET protocol. In spite of everything I just told you about the amazing benefits of cardiac rehab, the reality is that less than 25% of people who have a qualifying diagnosis ever get a referral. And there are reasons for that, and sometimes it's education, and that could be provider education, providers who just don't know about cardiac rehab or don't really understand the benefits, or patients who don't really understand what it's about or what it could benefit them. The other problem is that many parts of the US are what we call a cardiac rehab desert. 14% of adults live in counties that have no programs at all. And 75% of people live in counties where there's only one cardiac rehab center for every 100,000 adults. And those odds just aren't good enough to support all the people who have eligibility for and a need to experience cardiac rehab. In response to this, the American Heart Association, together with the Centers for Disease Control, developed the goal of preventing 1 million heart attacks, strokes, and other cardiovascular events in a 5-year period. And so their goal is that 70% of people who have a qualifying diagnosis would participate in cardiac rehab. But based on the things that we just said, you can see that we're a long way off from that goal. So they had a think tank where they got a bunch of people together to talk about the different barriers and how we could overcome them and how we could fix them, including developing flexible care models and different delivery patterns, referral patterns, and things like that. So I just want to take a couple minutes to go over some of those so that you know what's out there and what is potentially available for your patients. We already know that if we don't have a referral, then they can't attend the program. So lack of a cardiac rehab referral is probably the biggest barrier to participation. But also, like I said, people who don't really know what's out there, what's available, or what resources that there are to help them can be at a disadvantage for taking advantage of programs like this. People who are current smokers are less likely to attend cardiac rehab, frankly, because they are tired of people telling them that they need to get to quit smoking, or that they need to get healthier, or that smoking is bad for their health. They know all of those things, and they really don't want to go somewhere where they're going to get hounded. And so some education needs to happen there as well, because we don't require people to quit in order to participate in cardiac rehab. We do talk about their triggers. We talk about different adjuncts to therapy, and we encourage them to set a quit date. But we also have referral processes where they can get set up in a tobacco cessation program, or some people just don't quit, but we try to develop their exercise and their stamina as much as we can within that limitation. And so it's not an automatic, and hopefully not an automatic turnoff for people thinking that that is going to happen to them, that high pressure is going to happen to them. People who have a reduced ejection fraction, who have that severe heart failure, really have a lot of trouble just doing their activities of daily living. So they are people who have trouble just getting to the grocery store once a week. They don't leave their house very often. They just have no energy. And along with that comes this belief that they're never going to get any better, and that there's nothing that can be done, because a lot of people are given a diagnosis of heart failure and told that they have a 5-year lifespan. And I've seen people live a heck of a lot longer than 5 years with a heart failure diagnosis. I've also seen ejection fractions increase by 10 or 15% after participation in cardiac rehab. So the fact that they have a heart failure diagnosis should be the last thing that keeps them from cardiac rehab. It should be something that hopefully would motivate them to participate, because we can help increase their quality of life. Transportation or distance from a center. Like we said, some places are cardiac rehab deserts, but some people just live too far away, or they don't have transportation, or they don't drive. And so sometimes a lot of what we do is helping people to figure out solutions to this. If they don't have a family member that can drive them, or if they've just had open heart and they can't drive right away, sometimes we can set up ride to care and different programs depending on if you're in a city or out in a rural area. Some of the programs and the abilities might be different. Some programs can resource people with grant money for bus passes or things like that. So there are always ways to get around things. And we're very good at working with people to try to make it possible for them. Finances and copays are a huge issue. Like I said earlier in the program, some insurance companies have up to a $40 a visit copay, which is just unreal to me that that would be the case, but it is in some places. And so what we can do is oftentimes a hospital system will have financial assistance available. A patient can apply for financial assistance, and the hospital will oftentimes, on a sliding scale, be able to help with maybe 50% or 75%, or sometimes even 100% of their copay can be written off if they qualify financially. So it never hurts to have them apply for the financial assistance. Some places, some centers have grant money available or scholarship money available. So in other words, let's say you are above the threshold financially to qualify for financial assistance, but it's still just too much for you, and that is a barrier for you. Sometimes a grant or a scholarship can come in and offer you an opportunity to participate, whereas it would become a hardship otherwise. Some people get what's called a non-surgical diagnosis, or they are being medically managed. In other words, they have a cardiac cath and the doc says, well, none of the blockages were too bad for us to want to open them up yet, so we just want you to diet and exercise and maybe lose weight and manage your cholesterol, take these medications, and we'll just watch it for a while. And that can be a real downer for someone. It can also play with someone's mind, and they think, well, if it wasn't bad enough to have to treat, then I don't need to do anything about it either. And so that can be a barrier. People believe that, well, they're just going to wait until it gets bad enough and then they'll make a lifestyle change. Because let's face it, making a lot of lifestyle changes is not easy, nor is it fun. And most people won't do things like that unless they're pressed or unless they have a life-threatening diagnosis. Patients who are younger and who have work and family obligations just sometimes find it really challenging to participate in cardiac rehab. And for those patients, sometimes we can come up with a hybrid model, or we can direct them to programs that have early start times so they can work out and then go to work. We can help work with them with their employer and see if maybe they can understand that this is a medically referred program. This is something that their doctor is recommending for therapy, and therefore sometimes when you put it in those terms, an employer will allow someone to have a more flexible schedule during those 3 months of cardiac rehab and then revert back to their old schedule once they finish. And then lastly is a fear of exercise. Oftentimes people just think that, well, if I push myself too hard, I'm going to have another event. And while that may be true, one of the big benefits of going to cardiac rehab is that every time you go, we want you to exercise your hardest when you're there in the gym with us, when we have the monitor on. And so that way they prove to themselves every time they come and they don't have an event, oh, I just exercised and I worked pretty hard and everything was okay. It helps people to build confidence and empower them that they can go out on a walk on the weekends or maybe a short hike, or they can do things and start to build back the confidence when they're not with us, when they're not on a monitor and having their blood pressure taken, that it can still be safe to exercise. So now we come to who can refer to cardiac rehab. Right now, as of this recording, there is legislation in the works to make it so that mid-level providers are added to the list of those who can refer. However, currently, as of 2023, only an MD or a DO can sign a referral for cardiac rehab. That's just a Medicare guideline. And like I said, most commercial insurances follow that. So nurse practitioners, physician's assistants, nurses, MAs, things like that can initiate the referral, but it needs to be signed by a physician. And we are hopeful that that legislation is going to change. They're also trying to change who can be a medical director and making it possible for mid-level providers to be medical directors as well. So we'll see what happens down the line with that. I want to take just a moment to kind of discuss some of the ways that we can increase this referral process. And one of them, like we've already established, is education, helping providers and patients both to understand the value of cardiac rehab and the behavior modification that goes along with it. So that is job one. And then there are a few things that we can do within our hospital systems to make a referral diagnosis code automatically show up in the chart prior to discharge. In other words, anytime a patient has a diagnosis of NSTEMI, STEMI, stent, CABG, anything like that, on discharge, that a referral is automatically generated, and whoever the doc is that signs the discharge is signing off on that referral. So that's one way to change things. And then there's also the possibility that offices can do chart reviews and query and run reports on patients who have qualifying diagnoses to make sure that they are getting the most that they can out of the resources that are available to them in the medical community. But mostly it is a matter of patient education and physician education. So if you are working in an office or have access to a cardiac rehab program, see if they have flyers that you can place in your office, something that you can give to patients. I have some resources at the end of this presentation that you'll be able to print out, some PDFs that are downloaded into the course player for you, so that they're like cheat sheets that you can place near your phone tree area or your referral nurse or your physicians, so that it's a quick look at qualifying diagnoses and the codes that you can put in just to make it easier for you. And I just want to let you know that cardiac rehab has never been a revenue generator for a hospital system. It is almost in line with just a community service that we provide. And so this entire presentation is not a pitch to make more money for cardiac rehab programs, because we aren't in it for the money and never have been. This is really about doing what's best for patients and trying to decrease the incidence of heart disease and people who struggle with these conditions, and helping people in our communities to live healthier lives. One of the ways that we've been trying to increase participation is by expanding our concept of delivery of care. As we've already talked about, there just aren't enough centers to go around, and so sometimes a center-based program just doesn't work for a person, and yet we still need to find ways and think about different ways that we can provide that education and support for people. So there are different ways that cardiac rehab can happen. Traditionally, it's been in a center-based system where patients and clinicians are in the same place at the same time in a dedicated cardiac rehab facility. Sometimes this happens in a gym or a community center where there's a staff member that goes to that place and then performs monitoring and blood pressures and things like that. But that's the synchronous kind of in-person model is what we've always had. Now, COVID, for all of its difficulties, actually helped us in the way of Medicare for the first time, allowing hospital systems to bill for telemedicine visits. In other words, a real-time audio-visual or virtual visit where we could have people exercising at the same time that we're visiting with them. So let's say someone has a bicycle or a treadmill at home, that we could do a visit and we could watch them exercise. Education in that case could take place at the same time or a different time, but that's kind of the virtual model that we've been experimenting with. Now, there are places like Kaiser and the VA who are single payer systems who've been able to come up with some really creative ways to perform cardiac rehab, where they are doing a once a week phone call, they're doing education but not necessarily monitoring the patients, and just trying to support people's health in that way. But those types of programs aren't required to bill Medicare, aren't required to have qualifying diagnosis codes. And so they have a little bit more leeway with how they present care. And so they have actually been leaders in some of the new methods and new models of care delivery for cardiac rehab patients in the past. Also, over the past few years, there have been several companies that have come up with remote monitoring equipment that patients can wear while exercising off-site somewhere at home or whatever. And then the wearables can send data back to clinicians who can then review, like through an app or something else. And then they receive intermittent face-to-face, either phone calls, or maybe they come in every once in a while, or maybe 3 or 4 times throughout the 12 weeks, they come in for a face-to-face visit. There are a lot of ways to set up hybrid models with intermittent monitoring. And then education can happen in unique ways, either through websites or education that is assigned for them to view or things like that. So we kind of need to start thinking outside the box and making things possible for patients that work more within their schedule and their lifestyle and their needs, and not worrying so much about making sure that it's a traditional center-based program. While most providers are very supportive of cardiac rehab, I have actually met a few who are a little bit old school and who don't understand the ins and outs of cardiac rehab, who really do tell patients just go home and eat in moderation and exercise as tolerated and things like that. But in my opinion, that puts way too much faith in patients who have had a lifetime of bad habits. And in order to be actually successful at changing their behavior, in the end, it's difficult. So cardiac rehab is all about helping to identify patients, their barriers, their risk factors, and support systems, and then coming up with a way to put all that together to help them to be successful, because ultimately that's what we want. We want patients to be successful. And honestly, since Medicare and Medicaid and all the commercial insurances cover cardiac rehab, and because physicians are always looking for a way to resource and give their patients another option, then why not make the referral, right? I mean, let's give these patients their biggest chance at avoiding another event. What have we got to lose? You know, the patients have everything to gain. Like I said, in many ways, we are not only cheerleaders, but we are also educators and case managers, helping people to understand their medications, getting transportation set up, sometimes getting interpreters set up so that people who have language barriers, those barriers can be crossed. But ultimately, we have fun in cardiac rehab. We help people celebrate their accomplishments, and we actually genuinely care about them, and we call them when they're not there, and we become a community, and we believe in patients, and we help them to believe in themselves. So we become like a family, and we genuinely care about people, and we want to see them help build a better future. So I hope that this has been helpful to you, and I hope that you are coming away understanding a little bit more about what we do and why we do what we do. I hope you found this helpful. And if you'd like more information or more opportunities to take courses that will help you to personally further your health and wellness goals, I hope you'll visit lindamyersco.com. Here you will find some resources. There are links to several pages from the American Heart Association's website, which can give you access to flyers that you can download for heart patients that talk about cardiac rehab, what it is, and some frequently asked questions and things like that. So I hope you will find that helpful, or direct your patients to those website pages. And then also there is a PDF that is a cheat sheet that I've developed with the most common ICD-10 codes used for cardiac rehab. This is something that you can feel free to download and print off and have available for providers and referral staff and things like that. If you click on the paperclip anywhere that you see it within the course player, there's one in the top right corner, And if you click on that, the top will drop down and there will be a PDF that you can click on that is downloadable. Same thing within the left-hand bar of the course player. As you click through the different sections, under resources, there should be a paperclip that if you click on it, again, the top of the screen will drop down and the PDF will be there for you to be able to download.